Each slide, I'll just try to sort of make one important point that I think will sort of bring us all up to date of where things are right now with COVID. And as you all know, it hasn't gone away. This slide shows the estimated lives saved through vaccination. And it was modeled beginning when vaccinations first started in December 2020 through December 2021. So it's old data, but it's believed that close to 15 million deaths have been prevented through the vaccination program. So a huge reduction, 62% in the number of deaths globally. So it really has been a huge success. Was rocky at times, particularly you could see in Africa and some of the other countries in South America, Latin America are lagging behind because vaccine access hasn't been as good, but still everyone has benefited. If you look at this graph, what this shows you is this is over here is the beginning of the pandemic in March of 2020, and this spans until December of last year. The dark blue bars are the number of deaths that one would expect in the United States through all causes. And these light bars at the top are what we call the excess deaths, or deaths that were believed to be from COVID. So you can see it follows the peak, and it was a very significant number overall, and still quite significant. I'll talk about that more. Remarkably, in 2021, COVID was actually the third leading cause of death in the United States after heart disease and cancer. So that's a pretty astonishing and not good thing for a disease that didn't exist a couple of years ago to rocket into the third leading cause of death in the United States. Also, this news just came out a couple of weeks ago. In terms of life expectancy in the United States, we're at the lowest level since 1996. And that's probably for a lot of reasons. And then it started to sort of flatten out and go down even back here in sort of 2014, 2015 range. But it's had a precipitous drop in the last 2 or 3 years. Two of the biggest reasons are felt obviously to be COVID and also the opiate epidemic and overdose deaths, which are now over 100,000 overdose deaths a year. And, you know, when you're thinking about life expectancy, unfortunately, a lot of those overdose deaths are in very young folks, and that's going to take a lot of years off the overall life expectancy. So that's some downbeat news, but a little more upbeat is that we now have a third vaccine, and, you know, it hasn't been used a lot yet. About 15,000 doses have been administered, but it's available. And this Novavax vaccine is available only for the primary series, so for folks who haven't been vaccinated. And the difference is that it's sort of an old-fashioned, old-style vaccine that's sort of protein-based. It's not an RNA vaccine. And, you know, there were folks who had some concerns about the RNA vaccines, the mechanism of action, that they were so new. Although this is a new vaccine, the methodology that's been used is very similar to how we make flu shots and other vaccines. It has a good safety record. It works just as well as the other vaccines. And it's available for people if they want to choose something other than the Moderna or the Pfizer vaccine. It's not approved for use as a booster as of yet. What are we looking at right now? We're mostly looking at the so-called Omicron B5 variant. There were a whole bunch of variants, B1 through B5. The B1 is what we saw in that really massive surge last winter into the spring, which was really the most number of cases of coronavirus that we saw by far throughout the entire pandemic. It's been changing. It's still considered Omicron. There's about 30 mutations in that very important spike protein, which is what the vaccines key off of. So whenever that spike protein changes itself, it may have an impact both on treatments and on vaccines, because that's really what's being targeted with the current generation of vaccines. There is a little bit lower vaccine effectiveness, and then some of the monoclonal antibody IV infusions that we've been using don't work. If you look over here, this is middle of the year 2022, and you can see that these variants were predominant, the BA2 and the subvariant of BA2. And look how quickly, just between May and August, this BA5 takes over. And that's because whatever changes that BA.5 made it much, much more transmissible. So it has an evolutionary advantage in terms of spreading. So now it's really by far the most dominant variant. And that's really all you need to take from that slide. You can see, shown a different way, this was that huge surge we saw with the original BA 1.1 and then a BA1 subvariant. That was last winter and into the spring. And now we're seeing all BA.5. So we didn't get this big spike, which is a good thing, but we still have a lot of cases. If you look back starting in April, because of the transmissibility, overall spread out over time, there have been quite a number of cases. So we're still having a lot of cases. But the good news is, well, and here's a graphic representation just of the overall trajectory of the pandemic. And you can see back in 2020, although it seemed overwhelming because so many folks ended up in the hospital, that peak wasn't all that high. In fact, the December 2020 peak was even higher. And of course, this last winter Omicron peak was quite high, still getting a lot of cases. In terms of hospitalizations, the thing that's important to look at here, this is also looking at the whole pandemic, is that since April of this year, most of the hospitalizations that we've seen have been in older age groups, 65 or older, a little bit higher as you go up the age scale. Very few hospitalizations in the group of under 18. And fortunately, right now, we can see that all of them are trending down in terms of hospitalizations. But we didn't reach a super high rate overall relative to that Omicron surge. There were 100 hospitalizations per 100,000 people during that surge at the peak. We never got anywhere near that high. So that's good news, mostly due to both the combination of vaccine and natural immunity. The thing to focus on here, these are who is hospitalized, who was hospitalized over that year from June to May. Again, older age group, you can see that in that delta back in 2021, that wave, the average or median age was around 60. The first Omicron surge, the median age was around 64, and now the median age is around 70. Those are the folks that we really want to make sure are up to date with their vaccines and using all possible measures to stay safe. There was a trend also in folks who were hospitalized. It was more likely to be people with other underlying medical conditions. But you can see the good news is that the stays were shorter, on average 5 days, now 3 days. ICU admissions were much fewer, deaths and mechanical ventilation were much fewer. So the outcomes are much less severe. So that's great news. So even though we're seeing hospitalizations, even in the group that's hospitalized, they're not getting as sick or staying in the hospital as long. This is deaths, and it's a similar kind of a graph coming down now, mostly in the older age group. Is where we want to really focus our prevention efforts. How are we doing with vaccinations in the United States? Pretty well. About 224 million people have been vaccinated with a primary series, meaning 2 shots. So that's 72% over the age of 5. But then it begins to drop, and only about half of the population has received even 1 booster dose, and only a third have received 2 booster doses. So we hope to change that with the new bivalent boosters that are coming. Much less vaccination in the younger age groups, lower boosters in most minority groups, and people who are disabled are not as well vaccinated. And a lot of that has to do with access to the vaccines rather than whether or not folks want to get vaccinated. These are a couple slides just that want to show how well vaccines are working. So these are the rates of COVID-19 infection, okay, just whether or not someone tests positive in anyone over 5 years old. The black line is people who are not vaccinated, and the blue dot is people who had at least a primary series of vaccination. So you can see a huge difference in who gets COVID. Still, people can get COVID when they've been vaccinated, but there's a marked difference in terms of being vaccinated or not. It's about 2.5 times higher risk if you're unvaccinated. And these are the rates of hospitalizations. Again, looking at people who are unvaccinated is the green here. You can see there was a really massive difference in that Omicron surge in this dashed line here in that first Omicron surge were people who had had at least one booster, so 3 shots. You can see how hospitalizations were much, much less. You're about 5 times higher risk to end up in the hospital if you were not vaccinated versus having at least 1 booster dose. And this is also deaths, a very similar picture, 8-fold higher unvaccinated to die compared to folks that had, in the solid blue line is a vaccination with a primary series and 1 booster dose. You actually did very well just with the primary series only during this latest surge, but not as well during that first surge. This series of slides is really, I hope, to convince you that the vaccines really are making a difference. And of course, they can't prevent infection, but they are very, very successful at preventing severe illness, hospitalization, and death. So that's something to keep in mind. And we have a lot of data now, as you can see. So in terms of vaccine effectiveness during this Omicron period, which has now gone on for about a year, the effectiveness against severe disease continues to be higher and more sustained over time than the effectiveness against infection. And that's just a way of saying that, no, it's not 100% at preventing you from getting COVID, but it is very, very good at preventing severe disease. Still as good as the early days with the other variants. And the vaccine effectiveness during this latest kind of BA4 and BA5 variant predominance pretty much looked like the vaccine effectiveness during the earlier parts of the Omicron wave. This is important. We know that a 3rd dose, okay, so for folks who got a 2-shot primary series or a J&J and a 2nd shot, a 3rd dose really offers significant additional protection, okay, against both infection, getting COVID, and severe disease in all ages that they looked at. The effectiveness seems to drop less quickly than in that first primary series. That's not surprising because you've really boosted your antibodies. And that, again, is the same across all age groups. Right now, there are so few people who've really gotten the 4th dose that we don't have a lot of information about whether that 4th dose was helpful or not. But certainly the 3rd dose, we have very, very good evidence that it's prevented both infection and severe outcomes. Since this is relatively newer, the approval for kids 6 months to age 5 years old, I just thought I'd mention that. In terms of safety, it looks very safe. It's very consistent with what they saw in the trials. Local reactions like a sore arm or redness at the area are common. Nothing unexpected has been reported, and they don't think there's any higher risk of myocarditis, which is the heart inflammation that was sometimes rarely seen in younger age groups, the teenage group, with those RNA vaccines, but they're not really seeing that at a higher risk in the kids. So it is approved from 6 months up. This is the group that has not gotten a lot of vaccinations, although tend to have milder disease. So that's good news. In terms of the vaccine safety and booster doses, safety seems good. That there might be a slightly increased risk of myocarditis following the first booster dose, but it's a very, very rare event. Only 131 cases in people over age 5, over 123 million booster doses. So that's exceedingly rare. And most of those cases were not serious and the folks recovered. It's mostly in adolescents and young adult males, and they don't think there's a higher rate in kids 5 through 11 for the first booster. That's really something to, that we're aware of, particularly in that adolescent group. But it's such a rare event that it should not prevent anyone from getting vaccinated. In terms of where are we here in New York City, pretty good. Citywide, 90% almost have had 1 dose, 80% have completed 2 doses, but only about 40% have gotten that additional booster dose. Varies a little bit by borough, but in terms of completing the primary series, most boroughs have done pretty well across all age groups. The group that we've not done so well in is kids age 0 to 17. Only about 50% of kids have gotten 1 dose. 43% have gotten that full series, and a very small number have gotten boosters. So, that's a group that fortunately tends not to get severe disease, but we haven't done as well in terms of vaccinating. Cases in New York look like what we saw nationwide. They're definitely coming down now. So what's new? So just last Thursday or Friday, the group that makes recommendations on vaccinations is now recommending these so-called bivalent boosters. And what is that? It's only for the RNA vaccines, Moderna and Pfizer. But basically what they did is they sort of took a little bit of the Omicron and a little bit of the OG virus and stuck it together. So therefore it's bivalent. So it's not the original virus, it's a mix of the original virus plus what we've been seeing in Omicron. And it's really the very first time throughout the entire pandemic that we've sort of captured a moment where we may actually have a vaccination directed against the circulating strain. Now, we don't know how long the Omicron strain is going to stick with us. It happens to be very good and have an advantage at transmitting. So maybe it'll persist. And that's not such a bad thing because we're seeing milder disease with Omicron. But these bivalent boosters are going to cover both. So not only are you going to boost in your existing antibodies, but it's going to be targeted against the strain that we're circulating right now. And that's only for age 12 and up. So there's no more boosting with the previous vaccines. We hope to get them delivered actually very, very quickly, perhaps even this week. And it's pretty simple in terms of this sort of what they're recommending for fall booster reset. So we're not really dose counting anymore. Everyone is essentially eligible for this booster. If folks have not completed their primary series, they should complete that first with one of the RNA vaccines or the Novavax if they got that. But for everyone who got a primary series, wait at least 2 months and get this new bivalent booster. If you've been boosted once, wait 2 months and get the booster. If you've been boosted twice, wait 2 months to get the booster. So pretty straightforward. Anyone who's gotten that full primary series, don't worry about how many boosters you've gotten before. You're eligible for this bivalent booster. For those who haven't completed the primary series, as I mentioned, they should complete the primary series first. So that's what we're looking at this fall. I briefly mentioned Evusheld, an intravenous infusion. It's a monoclonal antibody approved for over 12 years. And this is for folks who are very severely immunocompromised, not someone who's got well-controlled HIV, not someone with a history of cancer necessarily, but someone who's actively on chemotherapy, or particularly for people who've had a transplant of any kind, kidney transplant, lung transplant, heart transplant, and they're on immunosuppressants. We know that the vaccine doesn't do as well in this group. And so it's recommended that every 6 months they consider getting an infusion of this as well in order to be protected. Also, anyone who's not able to get the vaccine because they've had a serious reaction to it, an allergy, would be eligible to get this intravenous infusion that gives you 6 months of protection. What about people who have COVID right now or just had it recently? And that's a pretty big group. I've been getting calls from patients who made it 2.5, almost 3 years without getting COVID. They're fully vaccinated, but people are letting their guard down, maybe not masking as often, maybe socializing a little more, maybe eating in a restaurant. We all want to get on with our lives. And so people are getting COVID. But fortunately, my experience with my patients, they've tended to be relatively mild, certainly not requiring hospitalization. And we can often use Paxlovid. But if you have had it recently, you could consider waiting 3 months because you probably get a boost from the infection. You should certainly at least wait until you've recovered from the infection to get the bivalent booster, but you're probably okay waiting up to 3 months before you get that booster. You can take individual factors into account depending how much there is around, and we're kind of on the wane right now, and how high your risk is. It's certainly okay to get it once you've recovered from the infection. And then what about other vaccines? Pretty much any vaccine you can get at the same time as you get your booster or your COVID vaccine. There's no really increase in adverse effects. They work as well. So for folks who are at the doctor and want to get their bivalent booster and get the flu shot, that's fine. You can go ahead and get both if you want to. It's also okay to split it up if you'd rather do that. A brief mention of long COVID, and unfortunately, we really don't know that much more. There are some theories that it could be circulating spike protein that persists, or a recent paper talking about perhaps sort of micro clots that can form in some of the small vessels of the lung, or that might be responsible for some of these persistent symptoms. Again, the good news is that we know that with vaccines, the incidence of long COVID is less. So even in folks who got pretty severe COVID, if you're vaccinated, you're less likely to have symptoms for a long period afterwards. Long COVID is really considered new or persistent symptoms that go on for 4 to 6 months after you've recovered. It can happen even in mild disease. Most commonly, it's respiratory symptoms. People, still have sort of shortness of breath, but you can also have fatigue or difficulty to sleep, depression, anxiety, brain fog they've talked about. Like the slide says, there's a lot we don't understand and just need to really help folks and encourage them that often things will get better, and hopefully we'll have a better handle on how we can treat it. This is a little bit of a crazy slide, but I wanted to talk a little bit about Paxlovid. This is a study from Israel where there was very high use of Paxlovid in a group of people that are very heavily vaccinated. I put red boxes around the thing to focus on, and basically that is where did Paxlovid make a difference? Okay, this Paxlovid is the pill, really a combination of pills, 3 pills twice a day that you can take for 5 days. If you started within 5 days of testing positive for COVID and you're older and at high risk. But where did it make a difference? It made a difference in people who are over 60 years old. People less than 60, not that much of a difference. It also made a difference in people with the risk factors of heart disease, neurologic disease, and immunosuppression. So those are the folks we really want to target with Paxlovid. But having said that, it's a short course, it's an abundant supply, regardless of the age group. Certainly, I think if you have any underlying conditions such as diabetes, I would definitely recommend it. It's pretty well tolerated, it works well. You've probably all heard about the so-called rebound, and that can happen after Paxlovid, although it may actually happen in untreated COVID as well. In other words, people sort of get a little bit better after 5 or 6 days, and then they get a little bit worse for a couple of days, then they get better again. So it's not clear how much of this is related to Paxlovid, but they're looking at whether or not perhaps a longer course of 10 days or retreating would be worthwhile. But certainly if you're over 60 or have underlying health conditions, I would consider using it. Ideally, you would talk to your doctor. And any physician, it doesn't have to be a specialist in infectious disease, anything, can access it. There may be on the Department of Health ways to access it if you don't have a primary care physician, but certainly the fastest way is talk to your physician, or if you went to an urgent care or a city MD, it's very widespread. Most doctors are pretty familiar with it. Most pharmacies, or a lot of the larger pharmacy chains, actually now carry it.
Okay.
There still is this one pharmacy, Alto Pharmacy, that we use because they'll deliver it. That was the sort of original one, the only one that had it. Now it's more widespread.
Everywhere. Yeah.
So that's how I'd go about it. It's important to get it within the first 5 days. That's when it'll really make a difference of 5 days of symptoms, not necessarily 5 days from your test, right? And then the second thing to be aware of is it does have a lot of interactions with other medications. So it's actually one of the medications that Paxlovid is an HIV medication that came out in 1995 that we mostly use now to boost the levels of other drugs. So it's considered a booster that we still use in HIV occasionally. It's called ritonavir. And so that's included in the Paxlovid to boost the active drug, which is a drug called Imralumab or something like that. So it's not really doing anything other than boosting that second drug, but it has a lot of interactions with other medications like cholesterol medications, some heart medications. Gotcha. If you're on HIV medications, even if you're on a booster, you don't have to worry about it. It's just 5 days, you take it, you don't worry about it. But you do need blood thinners, so you really want to make sure that you have a complete list of your medications before you start on that.
Gotcha. So if you're talking to your doctor, just make sure that sort of list of medications is up to date as you're requesting Paxlovid.
Yeah, I mean, it's unlikely that anything bad would happen no matter what on a 5-day course, but it's better just to be a little bit aware.
On the safe side there. Yeah.
So to sort of summarize, the CDC is continuing to monitor emerging variants as always. We all know that racial and ethnic minority groups were disproportionately affected by COVID throughout the pandemic. And again, that has a lot to do with access and, frontline workers. Fortunately, some of these inequities have decreased, but not been completely eliminated. The trend of increasing severe illness, hospitalization, and death is really in people of older age or with underlying health conditions. The currently approved vaccines offer protection against severe illness and death. I can't emphasize that enough. I mean, they really, really do work at preventing severe illness and death, even if they're not 100% of preventing infection. So it is important to stay up to date with the vaccinations, including your boosters. And we have lots of therapeutics. The one most commonly used is Paxlovid right now, just because it's easy. It's a pill. You don't have to go somewhere and get an IV and infusion. And the infusions are not really any better than the Paxlovid. And the Paxlovid does seem to work against Omicron. So what can you do? Get vaccinated and get boosted. That's the single best thing you can do right now. The bivalent booster is coming. Encourage kids and others who haven't gotten vaccinated to get vaccinated and boosted. Consider Evusheld, the intravenous infusion, if you're severely immune compromised. Consider Paxlovid if you do get COVID, especially if you're over 50 and have other conditions. And, continue to think about doing the old style things that we used to do, which is wear masks indoors when there's a high level of test positivity in the community. So things are kind of on the wane a little bit now, but things pick up again. Maybe think about wearing that mask in the grocery store, make sure the windows are open when you have people over, and so forth and so on. So those are the things that I think are still important. I think it's going to be very important to get the flu shots as well, just because we've had not so bad flu years the last 2 or 3 winters, mostly because people were walking around with masks and being very super careful. And as we're being a little bit less careful now, appropriately so, flu might make a comeback. It's important to get the flu shots also.